Good evening, everyone, and welcome. I know not everyone is done getting dinner, but I'd love for us to get started. We have an incredible speaker with us this evening, Dr. Sarah Armstrong, who I will introduce in just a moment. I met Dr. Armstrong as a medical student at Duke 10 years ago and was so impressed by her work, and am even more impressed now after reading more of your biography. So I can't wait for you all to hear about the incredible work that she's doing. I wanted to start with just a few announcements, though, before we get to our talk. First off, so lovely to see our familiar faces, but even more excited to see some new faces today. I'm not going to make anybody stand up and introduce themselves, so if you could quickly put your hand up if this is your first time here with us. Awesome. Thank you. We are very excited to have you. Some of us have these green little dots on our name tags, and that just means we'll be coming to introduce ourselves to you and welcome you to DOCMS and invite you back, hopefully next time. You can see we only have 2 more meetings after tonight, so we hope to see you there. We also have our first DOCMS family outing this year, which will be at the Durham Bulls game next month, and we hope to see you there. Obviously invite your friends and family, and it'll just be a nice time to hang out. We also have the LEAD conference with MCMS coming up in November, and so we hope that you guys will register and join us there as well. We do have a mid-year survey, so if anyone has their phone, we'll put it up again, but please scan the QR code. We'd love to get your thoughts about activities and get-togethers that you're interested in and events that you'd like to participate in next year, topics that you'd like to hear about, so please share feedback that way. Get closer, sorry. There you go. We also, just a quick thank you to everyone who participated at Kid Fest this past Saturday. It was a huge success. This is hosted by Piedmont Health, and they do it at 3 of their sites. This one was at our Carborough site, and so this was the first year that DOCMS helped to partner with them. Marion Cranford, our secretary and treasurer, got Ramsey's, the mayor, Barbara Fushi, and WCHL's Aaron Keck to be there at the ribbon cutting, and it was just a great time to be with the families of Carborough. We gave out about over 140 backpacks and supplies to the children of Carborough. So we're excited to have partnered and hope to do that again. So next, I would like to introduce our incredible speaker, Dr. Sarah Armstrong, who is a professor of pediatrics and population health sciences at Duke University. You can all see from the bio in front of you, she has done incredible work in the field of pediatric obesity. She founded and directs the Duke Healthy Lifestyle Program and also the Bull City Program, which has been running since 2009, and I can't wait to hear more about the incredible work that's been going on. She was awarded with the Outstanding Advocate for Children by the North Carolina Pediatric Society, and I'm sure many more accolades that I could go on about, but we're so grateful to have you here. This feels like such a timely discussion, not only for those of us in primary care, but a lot of us remember last year the AAP put out the clinical guidelines on the evaluation and treatment of pediatric obesity, and I was so excited to see that you co-authored that, which I did not know about. So we just can't wait to hear more about the work you've done and how we can all be better advocates for the children of North Carolina. Thank you, Dr. Armstrong.
Well, good evening, everybody. That was such a kind introduction. Appreciate it. Is it okay if I just hold this? Is that okay? All right. And is there a clicker, or should I just...
We're not that far.
No, that's fine. I sometimes wander. This is going to make me stand still. Okay. It's good. It's totally fine. No, I'm good. So it's great to meet everybody and to come to this meeting. I've never been to this meeting before, so I was one of the people that raised their hands. as a new person. And this is a really wonderful gathering of people. So thanks for the invitation. So yes, a lot has happened in the field of, I think, obesity treatment in general across the lifespan, but in particular for children. We have many more options than we used to. So I'm going to do like a very whirlwind tour of what we have available right now with a couple highlighted examples and suggestions for what you could try in your own practices and in your own community. So, and then we'll leave plenty of time for questions and answers. So this will really focus on treatment. And the reason that prevention is very important, and I think we need to do much more in the field of prevention. Seeing all the treatments pop up make me think, oof, if we don't want all our kids on medicines and having surgery, we better really lean into prevention. However, we have 14.7 million children in this country who already have obesity. They need our help, and we need tools and resources to help them as best we can. So we know that obesity affects both the immediate and long-term health of children. And so this really is central to the work that we do in primary care. My main practice is in primary care. So I'm going to cover the three big buckets of treatment that I often call them is lifestyle treatment, medications, and surgery. Okay. So this, I'm sure there's many other things we could talk about, but these are sort of where we have the most evidence and where we are seeing the need for it in clinic. So the past 5 years has been incredible in terms of what we are seeing in the field of pediatric obesity. We, as of 5 years ago, really didn't have much except counseling somebody on lifestyle or referring them to a bariatric surgeon. I mean, that is a huge gap in between that. And in the intervening interim, you can see in 2019, we had this statement guiding us in practice from the Metabolic and Bariatric Surgery for Adolescents. I authored that statement and really it took a deep dive into the evidence for the safety and efficacy of surgery. In 2020, liraglutide was approved for children 12 and up. In 2022, phentermine topiramate approved 12 and up. 2022, semaglutide was approved. And then in 2023, we had the clinical practice guidelines. And I'm just going to say Qsymia, phentermine topiramate, should stick with the trade names, is likely to come on brand and become generic maybe in the next year. And also, they're just finishing up a study of liraglutide in 6 to 11-year-olds. So we're likely to see that get FDA approved in the next year or so if it follows prior trends. So this is just coming fast and furious, and sometimes it's hard to keep up. But we tried to summarize most of this in the last year's clinical practice guideline, the evaluation and treatment of children and adolescents with obesity. So a lot went into this. I was really fortunate to be part of the scientific review committee that reviewed all the articles and did the literature review that went into it and the systematic review, and then be part of the writing committee to kind of put it into language that we can use in practice. We reviewed 16,000 articles for this. I mean, it was a lot. This was our work of COVID. This is people like, what'd you do over COVID? It's like, I read articles is what I did. So, we found that there was a lot out there. We ultimately culled down the quality of these articles. We had a pretty high bar for inclusion. And we found enough evidence to generate 13 key action statements, meaning 13 new things to do in clinical practice based on high quality evidence. 11 consensus recommendations, which means 11 things that we think were really, really important, but didn't have all of the evidence needed to meet that high bar. And then we published that all in two technical reports, one on screening for comorbidities and one on treatment. So a lot of stuff that went in there. I just wanted to highlight that it's very evidence-based. Are you guys hearing an echo or is it just me? Okay.
Yeah, we're hearing an echo.
Just talk loudly. Is there anyone listening remotely?
Yes.
There are.
Yeah.
Okay. Are you guys remotely hearing an echo?
Sarah, I can hear you. This is Jerry Matson. I'll see you soon. But yep, I can hear you.
You can hear me, but is there an echo? Because we're getting an echo in the room.
A little echo, but only when you just said that. But it wasn't as bad. But now, yes, a little echo.
Maybe I'll because it's not a terrible echo. Yeah. So all this to say is that not only was there a lot of evidence, but it was graded evidence. So I feel like we can say we can trust those guidelines. And I say that because when those so much social media pushback, people got really, they had feelings about that clinical practice guideline, both sides, you know, some on the, we really need to do this, why did it take so long? And some on this, you know, kids just need to exercise and eat healthy and it's their parents' fault. And so we, you know, and why, how dare you put kids on medicine? How dare you have kids go through surgery? I got a hate email as early as this, earlier this week that I had to forward on. So it's really interesting, but I go through this just to show that this is really evidence-based and high quality. So the document is about 180 pages. So don't expect anyone to read that one in entirety, but we did call it down to 1 page. You're welcome. So this is the algorithm for screening, diagnosis, evaluation, and treatment. It's got all of the elements starting with screening at the top. Diagnosis is only really helpful and tells you what to screen for and do. So in terms of what elements in the history, taking blood pressure, labs, and what labs to get and when. Okay, so I'm not going to go through it all, but that's all there in the algorithm. I print this out and put it in all our residents' workspaces so they can just go through and know exactly when they're supposed to get what lab. The treatment bucket is what we're going to focus on tonight. So it goes over motivational interviewing. I'm going to skip. It's an awesome topic, and I love talking about motivational interviewing, but not for tonight. It should be done for all patients across the span. It's just patient-centered communication. So I think it's good for everybody. Spouses, children, all of that included. So it's kind of good. So, but intensive health behavior and lifestyle treatment, we're going to go over what that is, weight loss medications, and surgery. That's what we'll cover tonight. But that's all in the algorithm if you want to refer to that. Okay, yes, that's what we're doing. Okay, so we'll start off with intensive health behavior lifestyle treatment, or IHBLT. And I think it's kind of hysterical that BLT is in the acronym. That's kind of fun. We didn't realize that till after it was published. We were like, oh, but that's okay. So what is IHBLT? So I think a lot of times the world expects us to, as primary care doctors, change people's entire lifestyle in a 15-minute office visit when we have to address 12 other things. That is not possible. I think everybody here knows that, but this acknowledges that. So IHBLT, in order for people to really change their lifestyles, they need intensive health, behavior, and lifestyle coaching. So what we found is that it really requires a referral to some sort of treatment program. And there was a dose effect that we found in the literature around 26 hours over a 6 to 12 month period, which is about an hour a week of nutrition and activity, engagement, and participation in counseling led to healthy outcomes. So nobody could do that in their office. You can't do an hour a week for every child who has obesity in your office. So it forces us to reach outside the walls of our offices and partner in the community. I'll give you some examples of that. It is the foundation, though, of anything else that we do. We should not be prescribing medications without doing really responsible lifestyle treatment. We shouldn't be having kids go through surgery unless they're also going through really supportive, family-based lifestyle treatment. So this is really the foundation for everything. And even by itself, it's shown to have a BMI reduction of about 5 to 7% over a year. So it works in and of itself, improves quality of life, improves nutrition and physical activity. So even as a standalone, IHBLT is really important. These are the components of it. So it should involve the whole family, which I think is probably self-evident to everybody here, that it's hard to have the child change their lifestyle and then go home if the parents haven't also changed their lifestyle. So really participation from the whole family. It really should start on diagnosis. I think in the past, we thought, well, maybe let's give it a year. Let's see how their BMI is next year. Maybe they'll grow out of it. The literature is pretty solid on that is not a good idea. So kids don't tend to grow out of it. They tend to get more severe obesity over years. They tend to gather more comorbidities, and then it becomes more and more difficult to treat. So we really do need to initiate treatment at the time of diagnosis of overweight or obesity. So it could take place, IHBLT could take place in a healthcare setting, could take place in a community-based setting with a linkage back to the medical home. It should include health education, skill building. I think it's great if it can involve parent training, at least 26 hours over a long period of time, not just like a 3-week program or a summer camp or something like that that doesn't tend to work from the evidence. And it can be group, individual, or both. Most evidence is for face-to-face. There's some studies looking at virtual ways of delivering them, but they really didn't maintain the same efficacy as face-to-face, which I think makes sense too. So here's a couple examples. So the YMCA is doing the Healthy Weight in Your Child program. Has anyone heard of it? We're doing it here. They have one at the Chapel Hill Carborough YMCA. There's one at the downtown Durham YMCA. And if you are on Epic and you type in YMCA into your meds and orders, if you have one locally, it'll pop up. This is for ages 7 to 13 with obesity. Adult participation are required. It's adapted from the MEND program, which is an evidence-based curriculum for IHBLT. It delivers all of those elements, the 26 hours, the family-based stuff. It delivers everything. There is good BMI change over 4 months. And the good thing is the YMCA can run this. They know how to do this. So YMCA of America has the curriculum. So it may take, if your YMCA locally doesn't have it, it's a great question to ask. Hey, could we have a Healthy Weight in Your Child program at our YMCA? I will refer you my patients. That's their number one complaint is they don't get enough referrals, but if you'll provide them the patient, they can run this program. There is a slight charge to families for participating, but like the YMCA does with all of their other programs, they have sliding scales and scholarships available. So they try to make it accessible. So that's one example of a successful IHBLT. The one that we do here in Durham is called Fit Together. And our program locally is called Bull City Fit. We asked the teens to name this. They wanted to name it Bull Fit. We were like, no. So yeah, this is teenagers, you know. So we compromised Bull City Fit, but this is a partnership instead of with the Y with Parks and Recreation. And Parks and Recreation is an awesome organization. I don't know if any of you guys have ever been involved with them. They do so much community-based stuff. Health and wellness, engagement with the outdoors, the Silver Sneakers program for older individuals. And so we partnered with them to create a IHBLT program. So we have one in Durham called Bull City Fit. We've also done, this is the focus of my research as well, we've done implementation studies in 10 counties across North Carolina. So we have Fit Together programs in 10 counties across North Carolina now. And so it's for ages 5 to 17. It's a 1-year membership for the whole family. There's 3 2-hour sessions a week, and it's mostly focused on fitness, but there is nutrition sessions as well. And it is evidence-based. Participation in Fit Together results in a BMI reduction at 6 months. So again, just another example of how a community partnership, either with the Y or with Parks and Recreation, could help you deliver IHBLT in collaboration with the community. So you're thinking, how do I set this up if we don't already have this or have one to refer to? First, I would start by checking in with your local Parks and Recreation and YMCAs to see if they already do it, because it might just be a matter of, I need to know how to refer to this. If they don't already have one, you can absolutely become part of this project. So we have developed online materials that are now free for use. So you can use this QR code I put up here. I can put it up again at the end to get to the website. And there is a Connect tab there. And if you just connect with us and send us your information, we can help you get set up with a Parks and Rec partner in your local community. They're really wonderful partners. Yeah, go ahead.
Would there be any way for Parks and Rec to actually in their own partnership with like the Boys and Girls Club of America?
So we did look into the Boys and Girls Club as a partner also. We haven't gotten any of those off the ground, but really for what we're doing, Parks and Rec is able to do it themselves. The key part of the partnership with healthcare, family medicine, pediatrics clinics, health departments, is there's a trusted health professional on the other line. And what the Parks and Rec people always tell us is they advertise for stuff all the time and people don't come. But when your doctor tells you that it's something you're supposed to do and they think it's good for your health, all of a sudden these kids show up. So they really rely on us for that part of that piece of the partnership. And it's been really beautiful. I mean, sometimes, you know, I'll have a patient who also has asthma and they'll message me and say, hey, you know, they're wheezing a little bit when they're running. And I'll be able to say, hey, where's your inhaler? And they don't have, you know, so it's a little bit of a nice closed loop situation too, to help improve their overall health. Great question. Okay, so because this is whirlwind, that's all I'm going to say about IHBLT, but again, happy to answer more questions at the end. I really think of all of the news focus on medicines and surgery, I think that actually the lifestyle programs are the most exciting and the most beneficial to families overall. So Okay, well, we have this whole new world where we have anti-obesity medications, and there's a lot of good evidence and there's a lot of controversy around it too. So we're going to go over both. So these are the FDA-approved medications right now for the treatment of obesity as a primary indication. So not for diabetes, just for, elevated BMI. So if you're 12 and up, you have orlistat, which nobody uses anymore, phentermine topiramate, liraglutide, which is the daily injection, and semaglutide, which is the weekly injection of the GLP-1. If you're 16 and older, you can take phentermine as monotherapy, and that's very cheap if people don't even have insurance over the counter. It's as little as $5 a month if you get the GoodRx coupon with it. And if you're 6 or older and you have a diagnosis of one of these named monogenetic conditions or Bardet-Biedl syndrome that's diagnosed, then you can get setmelanotide, which is a really interesting medication. It's a daily subcutaneous injection that acts on the melanocortin receptor, so bypasses a lot of the single gene defects in that pathway. The interesting side effect with this one is because it's acting on the melanocortin receptor, it causes skin darkening. The longer you take it, the darker your skin gets, and that could be problematic for some people and not for others, and so that's something we always talk about. But that's just more for rare gene defects. Did you guys hear about this? Like everybody heard about this, right? This was just last week. We've been advocating for this for a year with DHHS. They've always kind of been on our side that this was an important thing to do. They just needed to negotiate the drug prices down. They finally were able to do it. I don't know if it has anything to do with Novo Nordisk getting a new plan out in Johnston County, maybe. But good news is that North Carolina and Medicaid, all the plans are covering a limited number of medications. So Wegovy weekly semaglutide is their preferred medication. That's kind of what they would like everybody to start with. There are additional options for adults as well, including tirzepatide. So we've been successful prescribing this since 2 Thursdays ago, where we really hadn't been before. It does still require prior authorization, and there's all kinds of trouble with the supply, and I can talk about how we're working on that too. But just to go over the evidence for these medicines, since we're scientists, we like to see the data. So this is liraglutide, the 3 milligram daily subcutaneous GLP-1 receptor agonist trial. This was published in 2020 in the New England Journal. And if you can see on the left is absolute change in BMI and standard deviation, and on the right is the relative change in BMI. So you can see with the liraglutide compared with placebo at about a year, 56 weeks, you're getting a reduction of about 5 to 6% overall in BMI, which is pretty good. You can also see that when the medication is stopped, there is weight regain. And that's something we just have to acknowledge, that these medicines work when you're taking them, but it's, obesity is not like an ear infection or strep throat. It doesn't get fixed by these medicines. It's a chronic disease. So the disease resumes when the medication is stopped. This is what we call a waterfall plot. I kind of like it because what you can see is on the left are people who were responders to the medication. This is the treatment group with liraglutide. And on the right of the waterfall, where it goes up, you can see people who didn't respond. So at an eyeball glance, it's nice to see that more people responded that didn't respond, but there's still some people that don't respond to this. And that's really important because you get some people that get their hopes up, they've heard about some, and then it just doesn't work for them. And they're not necessarily doing anything wrong. There really is a percentage of people that these drugs don't work for, and we're not entirely, they do have to take them for them to work. Yes, exactly. Have to be sure about that. Yes, if they squirt it on the floor, it's not effective. But here's another interesting thing to note. Look on the other side. This is the placebo group. Same waterfall plot scenario. Left of the yellow line is people who lost weight. Look at how many people did so well in the placebo group. Placebo included an equivalent of IHBLT. So they're all getting lifestyle treatment along with this. So it does work for like a fair number of people without medication. So, clearly there's a difference, but I think we still shouldn't be giving up on lifestyle treatment. Adverse events are common, but thankfully mild with the GLP-1s, mostly gastrointestinal, mostly constipation, reflux, nausea, vomiting. from the effect of GLP-1s that slows gastric motility. Fun fact, the GLP-1s were derived from the venom of the Gila monster. It's a little lizard about this big in the southwest part of the United States. And when they inject their venom, it paralyzes the intestinal tract and they drag the animal away and then they die of starvation and then they've got their. So anyway, that's what we're using for GLP-1s. So it does slow our intestinal motility. So it does cause a fair amount of those GI side effects, but also the placebo group, there's a lot of GI side effects in people even with the placebo too. Okay, and then moving to phentermine topiramate. This is an oral medication. So for my patients that are just like, nope, when I talk about injections and they will not come anywhere near a needle, this is kind of what I go to. Phentermine topiramate can be prescribed as the single pill together, or it can be prescribed separately. And so while it's not covered as the single pill for many plans, it's pretty easy to do separately. So I know a lot of people do that. I'll give some prescribing tips in a little bit. But so placebo is in blue, the mid-dose phentermine topiramate in red, and top dose in yellow. So you can see even at the red, we're getting about an 8% reduction in the BMI. Okay, and this just looks at categorical BMI reduction. It's just another way to look at it. What fraction of people lost more than 5% of their body weight? And this one, it was about 50% lost more than 5%, but about 38% lost more than 10% of their total body weight. So this one's pretty effective as well. Adverse events for this one are obviously related to adverse events for the phentermine, which tend to be increased blood pressure, increased heart rate, increased wakefulness. I tell my patients, think of this like your cup of coffee, drink it in the morning, but don't drink it before you're going to bed because you'll stare at the ceiling and be mad at me. And then the topiramate for the cognitive slowing and sometimes sleepiness. So they looked for all of these adverse events in the combination pill, and they found a pretty mild side effect profile of this. The one thing that's really important to note is that topiramate is a teratogen. So this one does require girls of childbearing age have a reliable form of birth control and monitoring. They recommend every 3 months. I think that's a lot, but periodic monitoring for pregnancy. Okay, this is semaglutide, so the weekly GLP-1. Amazingly, I don't know if many of you looked at the data for adults because you care for adults too. This actually worked better for children than adults, and that's very rare in studies. Usually things work better in adults. But patients on semaglutide, age 12 to 18, lost between 15 and 20% of their body weight. I mean, that's getting close to bariatric surgery numbers, which is around 20%, 22%. So really powerful medication. And the weekly dosing makes it much more acceptable for patients, even those that are not a huge fan of injectables. They can tolerate it once a week. They don't have to do it. So, again, it's just by comparison, these weight loss thresholds, look how different this is than the one I showed last time. So 70% of people lost more than 5%, 60% lost more than 10%. So you're really seeing much, much greater efficacy there. And here's the waterfall plot. So you can see how this looks different than the liraglutide one, much more shifted to the side with most of the people responding, but still a small fraction that won't respond. So they are still there. And again, my favorite placebo waterfall plot showing the placebo group that are doing just beautifully with their lifestyle treatment. Thank you very much. So semaglutide also seems to be very effective in reducing comorbidities in children with obesity. So we see reductions in A1C, ALT, blood pressure, cholesterol, particularly triglycerides. We see a really big difference in this. So reversal of a lot of these comorbidities is obviously super important. Adverse events are common. Again, they occur at a very similar rate as the drug. So I think the take home is there's a lot of kids out there that are constipated. I think that's just what's going on. So I do some counseling with patients about how to avoid these side effects, but I'm not sure all of it is attributable in this study to the medication. This one is probably my favorite outcome because I think it gets to what's important to kids and families, and that's quality of life. And I was pleased to see that they measured this in the study, and it wasn't just all about weight. So this shows that patients on the medication to the right favors the treatment. So body esteem score, family relationships, physical comfort, social life, and then all of these together, all improved with effective treatment. So we're not just treating their blood pressure and their diabetes and their obesity. We're treating their ability to be regular teenagers and just engage in the world the way teenagers are supposed to. So I think it's really a really life-giving treatment for some. Okay, so here's a lot of the questions that I get from my patients and from the public. What happens after 1 year? Because all these trials were basically about a year. So I'll just put this all up here. So we really do have a research gap. We don't know for sure if there's cumulative risk if you keep kids on these long term. And we can look at the adult studies, and there have been some trials that have had patients on GLP-1s for 5+ years, and they all seem to be doing great. I mean, looking at the outcomes we're seeing from the adult studies, 20% risk reduction in cardiovascular mortality. Some of that's pretty striking, but there doesn't seem to be a risk increase that we're seeing. But we don't know yet for kids. We just don't have that data. So you have to be honest with people about that. And then, can we ever stop it? Right? I mean, I had a 12-year-old this morning that they came in and wanted this treatment. I had to have a very honest conversation. You're 12 and we're talking about this treatment, and it may need to be lifelong. I would like it not to have to be lifelong. Would I love it if we could wean the dose, or maybe go to every other week, or maybe even a once a month dosing eventually? That would be great, but that doesn't exist today. We don't know. So I think you have to be really clear that they can stop at any time, but the weight is likely to come back if they stop the medication. It makes a hard decision for families, especially with these younger children. Okay. So we also want to know if these medications are going to be quite as effective in real world populations. So all of the studies that were done, I didn't show you all the table 1 demographic stuff, but it's all kind of like middle class white children for the most part. I mean, they tried, I think, to bring some diversity in there, but they really didn't get much. So we're making decisions for all of the patients we care for in the real world based on data that's from a very small segment of society. So will it be as effective? I don't know. Will there be other side effects or risks that pop up? We don't really know. So I always try to use caution with that and applying data from one population to the more typical populations that we see. One of the most important ones is they excluded anybody with mental health conditions from these trials. It's like, well, in the adolescents I see, that's probably about half. So, I think it's just really important to just think about that. Okay, and then what about eating disorders? I get this one all the time. The Eating Disorder Society was really up in arms when we published the guidelines recommending medication. It is something we have to be careful about. Eating disorders are more common among people with obesity, and they often get missed. So I have had, I could probably count it on one hand each year, but it's, 4 or 5 cases a year where a patient comes in and they've been told, great job for all the weight loss that they've experienced, and they still have obesity, but they've really come down. And when I get into the conversation, they have anorexia. It's atypical anorexia nervosa, but it is anorexia. And I've had to hospitalize a couple kids for this. So we just really have to be careful about making sure that we understand what kids are actually eating, what their relationship with food is like. Are they restricting? Are they avoiding? Are they starving themselves? Because that is obviously a whole other problem that we don't want to create. The good news is that IHBLT, this is another reason why I'm a big proponent of it. If it's done correctly, according to sort of what I've presented here, it's actually protective against eating disorders. Because if you think about it, where are teenagers getting their advice for what they should eat and how they should exercise? Yeah, exactly. Totally. It's TikTok, or it's like their aunt, somebody who did some cleanse or whatever, and said it was a good idea. So they're getting all kinds of advice in the world that is usually not helpful. So if we get them into lifestyle treatment programs where we can really help them develop a good relationship with food and body positivity and, help them with that, it can actually prevent this stuff from happening. So I feel pretty strongly that kids who are taking this medicine should be engaged in some sort of lifestyle treatment program, not just to make it more effective, but to protect them and to keep them safe. And I know that's not always happening, especially with the expansion of these medicines. We currently do not have good screening tools for eating disorders among teenagers with obesity, which is kind of crazy. If you look at most of the eating disorder screens, they're people with underweight, and so the questions don't really make sense for someone in a bigger body, but that's being worked on. So hopefully you'll see more of those emerge. And then the question is like, should we start an AOM, an anti-obesity medication, if a patient does have a risk for an eating disorder? My first knee-jerk reaction was like, heck no. If anybody has any sort of disordered eating pattern, I'm not starting that kid on a medicine. And then, of course, I had a patient who changed my mind. A 21-year-old who said, look, I'm so distracted by my food thoughts all the time. It's making my anxiety worse. This is a teen who had been hospitalized for her eating disorder at one point. So we started with a lot of caution and a lot of worry on my part. And I just saw her last week and she's doing beautifully and said this was what she needed all along, was just for that food noise to go away so she could feed herself the way she wanted to. And she's, lost weight, but not too much. And she's feeding herself 3 healthy meals a day and finally started going to college. I mean, she just her life turned around. So patients teach you. Yeah, patients teach you. Yeah, that's right. That's right. Well, yeah. And I think listening to our patients and what they need, but then being really careful and monitoring them closely. I think so. We don't have good answers about whether or not to use these medicines based on these things. Okay. So these are very boring looking slides, but I just wanted to have on here info for prescribing, and we can send these slides out, just kind of tips and tricks. So phentermine topiramate, again, they should have a reliable form of birth control, no glaucoma, hyperthyroidism. I use caution in patients with hypertension because the phentermine. And I try not to do this when somebody's on a stimulant or a monoamine oxidase inhibitor. And they should be willing to engage in lifestyle treatment. The reasons I choose phentermine topiramate is if there's some sort of contraindication for a GLP-1, or they absolutely won't do the injectable, or they don't have coverage. Side effects, a little bit, blood pressure can be a little jittery. The cognitive slowing, I mentioned these before. There can be a metabolic acidosis with the topiramate. So I usually do a baseline pregnancy test and then monitor BMP and pregnancy test about every 3 to 6 months. So if you want to write Qsymia as is, you can start off by, it comes in 4 doses. Write 2 scripts to start with for the first 2 doses, let them ramp up, check them, and then be able to write the next one and do it that way. But if you want to do it off-label because they don't have coverage, I usually start with 50 milligrams of phentermine in the morning, 15, did I say 50? 15, and 50 milligrams of topiramate in the evening, starting with 25 and then going up to 50. So that's sort of the poor man's version of that combo. If you don't have 5% weight loss on any of these after about 6 months, I stop because they're probably a non-responder to that medication and just try something different. So some practical tips for prescribing semaglutide. So same indications as the phentope, except exclusions include if you have a history of medullary thyroid carcinoma in the family or MEN syndrome. There is some evidence of increased risk of thyroid cancer, although it's only been shown in animal models, not validated in humans, but it's still there. The reasons I would choose this is if they have more weight to lose, or if they have diabetes or pre-diabetes, it's just a good match. If I don't think that they're going to be compliant with a daily regimen, the weekly one is actually really nice. It's much easier to remember. And if they have coverage, which now includes any federal employees. So the federal employees have had coverage for all of the medications from January 1st, 2023. So that's been a while. State plan was and then wasn't. Now it's still not. UNC does, I think. Duke does not. And then now North Carolina Medicaid. So good times. We have to remember all that. I always talk about the side effects. I give them a little 4 milligram sublingual Zofran to take home just in case they get nausea with the medication. But I think the best thing to do is get one of the little demo pens and show them in your office. It is honestly the best way to allow teens to really feel a little bit of autonomy and control over this process and just show them how it works. And that usually works for me. I start off writing the 2 first scripts, the 0.25 and the 0.5. follow them up in 4 to 6 weeks, and then we discuss whether or not we go up. I'm telling you, I have a couple patients that have stopped at the 0.5 and they're doing beautifully, and I see no reason to increase if they're doing great. So there may be a problem at some point that you have to go up to the top level, but for now we haven't gotten pushback. So I'm just letting people stay where they're responding. Okay, that was just practical. Okay, what about surgery? So notice that the recommendation here is not to do surgery, it's to offer a referral to a comprehensive program. And so this is a recommendation starting at age 13. Duke has the only credentialed adolescent bariatric program in the state of North Carolina, and we start at age 14. All the surgeries are done at Duke Regional Hospital. We do all the assessment in Healthy Lifestyles Clinic and getting them ready, and then they do the surgery, and then we do the follow-up. So it's a very comprehensive program with a lot of wraparound care. So who would you refer maybe for surgery? And then like, how do we talk about that in the office? I think it's super helpful if their primary care doc has talked with them about it a little bit, because otherwise, you know, I feel like I'm laying on them some pretty big news when they show up in my clinic. But really, age 13 and older, BMI greater than 35 or 120% of the 95th percentile on those new curves, with comorbidities, or a BMI of 40 or greater, 1/40th%, even without comorbidities. So a lot of kids actually meet that criteria. And so the way that I talk about this with my patients, and feel free to steal the language or use something different, whatever you're comfortable with, is I tell them that I'm kind of like a waiter in a restaurant, and I'm going to give you all of the options that you have here, and I'm happy to tell you more about them. I'm happy to give you my personal recommendation for you, but ultimately the waiter doesn't tell you what to order, you choose. And I think it's really important, especially for teenagers, that they feel that sense of autonomy and control over this process, because it's a commitment. The medicine's a commitment, the lifestyle's a commitment, surgery's a commitment, whatever they pick, it's a commitment. So they really should be the ones choosing. And then I try to normalize that all these options are available to them. And would they like to know more about any of it? I find that a lot of patients have life experience that informs how they feel about, you know, they have a mother, grandmother, aunt, uncle that has been on medicine and done really well, or had surgery and did really terrible. And, you know, so that experience really informs how they feel about it and the questions that they want to ask you. So that's kind of how I frame these. So there's some questions people ask about, why wouldn't we just wait until a teen is older? Why do surgery in adolescence? But there's actually some really good data that as young adults, so 18 to 25 is compared with adults 35 to 55, they actually do better in terms of weight loss, fewer complications, and greater improvement of their comorbidities. Oh, thank you. You're so sweet. In general, they're just healthier people, you know? And so they really have an ability to be able to bounce back from the surgery and do well. Thank you. I was losing my voice. I'm talking in clinic all morning. So then if you look at young adolescents versus older adolescents, even if you look at the 13 to 15-year-olds versus the 16 to 19-year-olds, they actually do a little bit better even then too, and have less of the iron deficiency and some of the other challenges we see. So there's nothing to say we really shouldn't consider it in this age group. There's no evidence that it impairs growth. I'm going to show you some of that. I guess, you know, one of the most compelling things that I've seen is kids that were not living their lives, because these kids that get surgery, they have really significant obesity, right? They may be homebound, not going to school, they're not on the dating scene, you know, they're really restricted because of their body size. And I've just seen kids just really be able to explore what their passions are, what their dreams are, what they're good at, by being able to go through this process. So I do think it's something important to consider with all patients with severe obesity. Few contraindications: if they have a medically correctable cause, so they have Cushing's or hypothyroidism, if there's an ongoing substance abuse problem within the past year, or an ongoing poorly controlled mental health condition, just having a mental health condition is not a contraindication, but it needs to be addressed and well treated, well managed at the time of surgery, and current or planned pregnancy within 18 months. A quick note on mental health and surgery. I always tell my patients going through it, I say, you know, bariatric surgery is going to help improve your blood pressure. It's going to help improve your diabetes test. It's going to make your sleep apnea go away. It is not going to treat your depression. There's depression treatment to treat depression, but bariatric surgery does not treat depressions. We got to do both. I think a lot of people feel like I'll be happy when, and that's the thinking, but that is flawed thinking, and the studies bear that out, that mental health stuff really doesn't change all that much after surgery. And if anything, we're kind of giving kids an adjustment disorder for a period of time while they're losing weight really quickly, and I think they require actually more mental health support, particularly in the year after surgery. So just a note to make sure that teens don't have that misperception going into it. Okay, and so how do you do it if you want to refer a patient? If they're 18 and younger, send them to the Duke Healthy Lifestyles program. And if you're on Epic, that should be in the meds and orders. And if you're not, there's other referral pathways. If you don't have one, let me know. I think we've been around for about 20 years. I think most people can refer at this point. Surgery can be done age 14 and older, Duke Regional, as I mentioned. And we do the preoperative evaluation and screening. We do a teen group that they participate in where they talk with teens who are pre-surgery and teens who have gone through the surgery, because it's different for them and they can kind of talk with each other. What should I expect? You know, who should I tell? Who should I not tell? Like all the things that grownups don't necessarily think about. Most of the time we're doing the sleeve, not the Roux-en-Y, for a couple of reasons. One is teens often don't have quite as much weight to lose. There's fewer complications. And if they were to gain the weight back and needed to stage to a Roux-en-Y later in life, they could still do that. So it gives them options later. Okay, there's a few nutritional deficiencies that are known. I won't go into them, but that's why it's important to get this done at a really experienced center that's worked with adolescents and can manage all of this with nutritional support. Bone mineral density is another thing that people are concerned about. We do know that teens lose some bone mineral density about 2 years after surgery, but it's still within the reference range. So there's still more evidence to come about that, about bone health. I think one of the biggest things we see is pregnancy, honestly, post-surgery. And you have a teenager who maybe has not been in the social circles and normalized to attention, and then all of a sudden they are. And so we've had a number of teens then become pregnant pretty close after their surgery. So we've taken to offering birth control at the time of surgery, either an IUD placement intra-op while they're there. They can do that if they want. Nexplanon placement if they want to do that. But we do try to counsel teens about the importance of that. Okay, so that's what time is it? Okay, close. Take home points. So obesity treatment for children and adolescents is recommended without delay. We have lots of good evidence now for all of these buckets of treatment, IHBLT, medicines, and surgery. But that IHBLT is really the foundation. And so when we start thinking about prescribing, the question should always come up, how are we going to get the teens that important lifestyle support? And you can send us patients if you want any of those three, or if you want help managing those three. So you can refer to us. You can do the e-communications that we have now. If you want to manage it in your practice, but you just want some help and support deciding on medicines or monitoring or what's the appropriate treatment, we can help you remotely that way too. But we can do all of those treatment options. And that is all of our info. So if you ever want it, and 2 of our patients. So, all right, any questions? Thank you. Happy to have discussion. If there's questions or comments.
What you just shared just really has my mind reeling, because I know of young people, and I also have some friends and colleagues who have had this dramatic weight loss, and then they're back into the dating realm, and they don't know how to navigate it at all. And there's so many psycho-emotional vulnerabilities that it almost says to me that there needs to be some sort of intensive work around how do I navigate the world of dating and romance with this new me when I still have all of the not enoughness, the self-doubt, and the low self-esteem that makes me vulnerable to just about anyone.
You do behavioral health, don't you? Yes. That was like so clear. Yes, all of that. I mean, like I said, and it's adjustment disorder. It really is an adjustment disorder. And I've had teens tell me things like, I walk around angry all the time because my mouth is hungry. You know, just like they're so used to being able to do things one way, they can't do it anymore. And they're just, you know, really upset and angry. It takes about a year to really get through that. And I agree. I think everybody needs support through that. And I think, you know, we're doing that really well for bariatric surgery because we have these like well-formed pathways. But I mean, I showed you Wegovy is about the same weight loss as the sleeve. I mean, we're talking a few percent different. I think we should be doing that for patients taking Wegovy too, because they're losing just as much weight in a short period of time as well. Yeah. Do you have a question back there? There was a question. So, oh, right here. Yeah.
Good weight loss for about 6 months. On average, and then a plateau is long as stop the medication, they go back.
Correct.
Does anyone said that stopping at randomized people to control placebo versus continuing?
So that is exactly what was recommended in an NIH workshop last fall. So I think that research, we're like in real time right now. That is going to be probably, you're going to start seeing studies that'll do all kinds of things. So randomize them to a lifestyle program versus a low dose versus staying on it, and trying to see what we can do once people hit that plateau and they're at a good place to help them maintain without having to take the same dose the rest of their lives. Yeah.
And all those showing weight loss in terms of percentage of body weight. We have to show in terms of what the goal is, what we're aiming for. How close do we get what we consider really healthy?
Another really good question. I also don't think we know. The question is, what's the bottom? Because some patients keep on losing weight. They're like, okay, I'm done. I don't need to lose anymore. When do I stop? And that's a really tough question. I'm dealing with that with one of my patients now who feels like her body wasn't meant to be as thin as it is now. And she's not sure if she should go back up again. So, you know, what I tell patients is I say, I don't know where your healthy weight point is going to be, but what we need to do is we need to really just pay attention to your body. When do you feel good? You have energy, you feel strong, you can do the things you want to do. And when I'm looking at your lab test results, everything's looking good and normal, then maybe that's your healthy place. And maybe we should try and reduce the dose to kind of keep you there. Because I don't think we know the answer to that. Yeah. Yeah.
You know, you may have said some of this information that I may have missed, but I'm just curious what happens to these people in the long run, and how have you followed them? Have you followed them that long, or has somebody done that?
Yeah, so the medications have really only been approved in children for a couple of years. So we don't have much experience following people long-term, but we've been doing the surgery program since 2011. So we have a lot of kids that we follow long-term there. And interestingly, and I think you guys see this in the adults too, is a lot of people, it's not just a choice of lifestyle or medicine or surgery. Sometimes it's and. You know, I have a lot of patients who had surgery and then lost weight and then plateaued and maybe started coming back up again. And now we're starting medication with them to help them kind of get back on track. And I hear that, you know, every time we do this, I hear that the parents always tell me what they're doing. You know, I had this. And so I'm not an adult doctor and do not pretend to be one. But that seems to be happening with a lot of adults too, is surgery and then GLP-1s after that. Yeah.
I had a patient who is 2.5 years old, coming for a well child check. She weighed 58 pounds. And it was a really hard discussion. The mother started crying. It was just like a whole thing. And I'm just curious, like, at what point do we discuss this? Like,
I mean, there's really good data that if you have obesity by age 3, you're almost, it's about a 90% chance that you're going to keep that obesity into adulthood. Like, it's almost irreversible. I hate using that word because it sounds so like hopeless, but I don't think there's a thing as too early. I mean, you guys see pregnant moms, like maybe that's a good time to start talking about it. Is, honestly, there's good evidence that mom's behaviors influence, fetal birth weight or infant birth weight and birth outcomes. Gestational diabetes that's uncontrolled makes the child at risk for diabetes later. So I don't think any age is too young. It's hard. I totally hear what you're saying, having that conversation. I always try to tell, the first thing out of my mouth is, welcome to healthy lifestyles. And I just want you to know this isn't your fault. I tell the child, and I look at the parent and I say, and it's not your fault either. There's a lot of biology that happens here. About 70% of obesity is genetic. So, okay, we can work with that 30%, great. We'll do everything we can, but it's not your fault. And so just trying to normalize that a little bit with patients so you can meet them where they are and help them set goals that are meaningful for them. Yeah. But we see patients 23 and younger, and we see a lot of toddlers. So we do genetic testing and some too for really severe cases of obesity. Yeah. Another one thing that people often ask about is what should they be doing for exercise when they're taking GLP-1s? And I think it's really important that, when you're taking these medicines, you're losing weight, and that weight is both fat and muscle. And losing muscle is not a good thing, right? Because it reduces strength, but also it reduces your insulin sensitivity. So it could make prediabetes worse if you lose the muscle mass. So when I'm having kids take GLP-1s, I also recommend that they eat protein first. So I say, if you've got your plate of, spaghetti, meatballs, and green beans, I want you to go to meatballs first, which is like opposite of what every nutritionist is telling you, right? But you're going to be full before you get too far in the meal, and I want to make sure you have some protein to preserve your muscle mass. I also ask them to do at least 3 weight training sessions per week. The cool thing is, like, weight training is cool now. Like, even with the girls, like, there's all kinds of influencers that are out there that are body positive, and I'm happy to help. So I tell them do a push day, a pull day, and a leg day throughout their week, and then they'll be, just to maintain that muscle strength. So those are just some exercise recommendations too.
Yeah. Do you know what 10 counties, list off the 10 counties that you're?
Oh, yes.
Is one of them Chatham County?
No. Sorry. Yeah. So it might be hard to remember right now, but I mean, so Goldsboro, what is that? Wayne County and Montgomery County, and the one right next to Montgomery, Richmond, and Salisbury, which is in, what county is Salisbury in? Rowan. Did you say Rowan or Rowan? Rowan. Okay. Okay. Are you from there? Okay. All right. See? Okay. Rowan. And Wake County, Mecklenburg, Forsyth, so it's Winston-Salem. Yeah. Yeah, and I'm missing someone too, but yeah. So we've got programs there, so you can always check with your local Parks and Rec department.
Anything in the mountains?
I've not gotten anything in the mountains yet. I feel like that'd be so fun though. Yeah. You have ideas? Okay, you can come talk to me after. Yeah.
Anecdotal clinical observation about some patients who use word gluten end up losing weight.
Yep.
There's no
yeah, so it's not approved in teenagers, but it is part of the adult weight management talk. So Contrave is bupropion and naltrexone combination, and that has been studied and is actually quite effective in many adults. So it can be a good, I always, if I have a team with depression, I want to use my first line agent for the depression, but if they have to add one or if they fail first line, Wellbutrin's not a bad choice for depression. Yeah. Yes.
When it comes to, when we talk about situations that have some kind of lifestyle influence, this could be a huge question if you say one or two things about it. What about children in other comparable societies? What happens? My son and grandchildren live in Japan. You don't see a lot of overweight people, but
Yeah, unfortunately, the global burden of obesity is just increasing now, and it seems to be spreading like with Western culture, sadly. as our influence spreads, so do our health problems. Yeah, but there are some cultures that still have maintained a fairly low rate of obesity. Japan's an example. And then there's some places like the Pacific Islanders that have very, very high rates of obesity. So, you know, it's hard to know why or where, but they call it the nutrition transition, particularly when third world countries kind of modernize their food industry. Obesity typically follows. Yeah.
If we look at the problem as a public health issue in terms of families who have siblings who have children who are obese, that if the diet of the child between birth to 2 years is controlled, is there any studies where that child will develop differently?
Well, so controlled feeding studies in birth to 2 would be pretty hard because usually you have to hospitalize people to do really truly controlled feeding studies. As soon as people are out in the real world, you know, they do real world stuff. So we're doing a study right now where we're randomizing 12-month-old infants who are Medicaid and WIC eligible to one of 2 food security interventions. Either they get $50 a week at Food Lion as a grocery benefit with the nutritionist to help them shop, or they get $50 a week for a year as a debit card, and they can spend it on whatever they want. And we have a control group that we're looking at that is not involved in the study, so we could just compare growth trajectories. So the hypothesis is, if you fix food insecurity, can you prevent obesity? I mean, I like to stay hopeful on that question, that if people have the resources they need to feed their families the way that they want to, then maybe we can, but we'll see what happens versus the controlled feeding versus the free range, let people out on their own feeding. Yeah.
There's lots of cultural issues in food, but psychological meaning. I think the famous study here in North Carolina about the Cherokee population, but they expect everybody to become diabetic by the time they reach 40 years old. I mean, really changing lifestyle, medicine, and changing their diet prevented those people from reaching that predictable outcome, developing diabetes. So the issue is that, my understanding is that if the child is obese in the formative years, that there is multiplication of fat cells.
It is. Yeah, it's very difficult to reverse it if they develop it in early life. I agree. I think we have a lot of efforts aimed at that early age group. There's a whole group at the American Academy of Pediatrics focused on birth to 3, just really aiming at like, what are the healthy habits we need to develop early in life to prevent obesity? Because you're right, once it happens, it's really tough. It's really tough to treat. Yeah, thanks. It is a public health problem. I agree. Yeah.
With your family in Japan was one of the zones that people have talked about. I'm more probably plant-based, focused diet activity throughout. What you didn't talk much about plant-based diet. Yeah. I'm curious of how that is within the pediatric team. Plant preferred. You know, I know vegan is hard, but in terms of that, do you have any thoughts on that?
Yeah, I mean, so we try not to get into specific sort of dietary trials where we're testing one diet against another in kids, mostly because I watched the adult literature battle it out. It's kind of a gory field. They all think they've got the answer and the best one. I mean, I think the most recent meta-analysis of all those studies showed that the Mediterranean diet is probably the best of all of them. So we tend to counsel families on a Mediterranean type diet. However, when you're dealing with children, you're also dealing with the picky eater, the one who won't touch vegetables, the one who their food can't touch each other on the plate. And so we've got all kinds of other things that we try to kind of make it work as best we can. But definitely a focus on, I like to say vegetables and fruits, not fruits and vegetables, because I think vegetables are actually more important. So focus on vegetables and fruits, healthy sources of protein, healthy sources of fat. Let's not be afraid of that. And work within whatever the barriers and constraints are. Yeah. Yeah, good question. I mean, the interesting thing is you never know. I saw a patient this morning, we had this exact conversation because he and his brother are best friends. They do everything together. and he has obesity and I'm treating him, and his brother's a beanpole who could take or leave food. I mean, the rest of the family is like, we don't understand him. He just says, it's okay, you know, and the rest of them are like super Southern foodies. So it really does, I really just think it gets back to this is genetic. And the one child has something about him that increases his appetite, his satiety is different, his metabolism might be different. And so he has a, you know, a phenotype that just looks very different from his biological brother. Yeah.
We talked a little bit about the adjustment period that can happen after patients are getting surgery, and how some patients that have depression beforehand are likely to go through kind of a harder adjustment period afterwards. My question is whether or not you anticipate that and you actively start already planning a regimen for that, because I can see how now a child who's not homebound, who's going to school, who's maybe on the dating scene, who can go play the sports they always wanted to and be outside all day, that can, you know, potentially minimize some of the depression that they have.
Yeah, oh, it's such a great point, and I can tell you're a prevention person at heart, because that's exactly what, you know, we try to do. Just to clarify, I don't think it's just the kids with depression beforehand that have trouble with the adjustment. I kind of think it's everybody in their own way. But I do think it's a great idea. One, we have to get the depression managed beforehand, because we just don't want them to have that outcome or make a decision in a mental state that is not fully, you know, like intentional about that decision. But I have done exactly what you're talking about. I start telling kids the story of all of my other patients and what they've experienced for the year afterwards. And I say, you've got to expect that you're going to feel like jumping out of your own skin. You're just going to feel like you don't really belong in your own body for a while. That is normal, and it's going to get better, you know, with time. And so I try to prepare them for it so that they're ready for that. Sometimes it helps, sometimes it doesn't. But if, you know, but we do have them all see a counselor as well that kind of walks them through some of those stages beforehand. Yeah. Yeah, good question. Yeah.
Teenage autonomy and his like decision making. I'm curious how often you deal with like parents who are pressuring their kids into one decision, or are the ones really making the decision, and how do you like balance that?
Yeah, that is really hard, and I see it on both sides. I see some where the parent is like, oh, you really should do this treatment, and you can tell the teen is a little bit like hesitant about it. And you see some teens that are like, I really want to do this. And the parent's like, no, we're doing it the natural way, or that's the most common answer I get. And so I think that all comes down, honestly, to just relationship building with people. And I always tell them, like, these are your choices. They're your choices today, and they'll be your choices again when you come back and see me in a couple months. So here's some things to read about. Here's some things to talk about. If you have questions, message me, and let's just revisit these options in a couple months. I often find people just need to sit with decisions a little while. We've had a couple. I mean, I had a mom make a decision with her teen daughter that she was going to have surgery. They're both completely on board. They knew all the requirements. Dad brought the patient to the next visit, and apparently he had not been informed that this was happening. And he almost tore my head off when I came into clinic asking about the steps. And so we had to kind of back away from it and go back again about what the rationale was, and that this is always a choice and you can change your mind. But we do definitely, there's differing, you know, opinions from a lot of different family members, and people tend to have strong feelings about the weight stuff, you know, and what you should do. Like, you know, you should just be on this diet, or you should get this or not get this. Or the other thing I try and stress is that taking a medicine or having surgery doesn't mean you failed to do lifestyle right. It just means you're taking advantage of your treatment options that are out there for you. And that is smart and healthy for a teen to learn that they should go seek treatment when they need it and look what their options are. So try to reframe that one. Yeah. Jerry. Hey.
I know we're running. Question about the youth and young adults that you're treating, and how much are they able to feel, like how much of the youth voice is in the messaging and some of the things that you're doing, and like some of the materials that you're creating, and
Yes. Well, I would love to co-create some materials with DHHS, Jerry.
You know, we would love.
There really aren't enough out there. So with medications, I mean, the materials, I give people the materials, the commercial packet from, whatever, the manufacturer, because it's got the ramp up schedule. It's got a lot of good information in there. It's got pictures of like old white ladies all over it. And I'm like, these are teenagers, you know what I mean? Like, make them feel like this is for them. So no, there's not a lot of teen friendly materials for the medications for sure. For surgery, when we got started, we used to have them go over to the adult bariatric surgery and do the groups because they existed. And then we realized that you'd have like a 15-year-old sitting next to a 55-year-old person who's got a colostomy bag and is in a wheelchair, and they're just like, terrified. And so that was real wrong. And that's why we've created these teen groups. The problem is there's so few of them and they come from all over the place to get surgery. So it's a Zoom group, actually started by one of our former patients, and she still runs it. It's called Oceans. So she hosts these twice a month little groups, but it's by Zoom. So we're trying to make it a little more teen friendly, but the obesity world is very adult focused, and that's what most of the messaging looks like. Yeah. Okay. I
We want to be mindful of everyone's time, but I do want to say we will send out some resources like we've been doing after each meeting to share. And we hope that these conversations continue. We just want to share very quickly the CME code for the evening. 1 second. Okay, so it's up there, but you can text the number with the CME code for this evening. I think everyone can see it, but DAVYUL, and we'll post it in the Zoom chat as well. Also, just a quick reminder that this is the last month for our half-off discount on both DOCMS and NCMS membership. So we hope that especially our new folks today will consider joining us and being a part of this group and continue to engage in these amazing discussions. Thank you again. And lastly, just our mid-year survey. Again, we want to know what you guys want to talk about for next year. Thank you all again.